During nutritional rehabilitation, the risk of mortality spikes the moment food is reintroduced to a severely starved patient. Introducing new calories triggers refeeding syndrome, a severe metabolic shift that can cause rapid cardiac and neurological collapse. Safely rehabilitating these patients requires the precise, systematic manipulation of their cellular physiology. To navigate this crisis, clinicians rely on a specific clinical countermeasure, the REFEEDING Protocol, a codified checklist designed to prevent systemic failure. We are going to deconstruct this mnemonic to expose the strict physiological imperatives hidden behind every directive. This process involves 3 distinct phases: establishing a safe baseline, deploying metabolic correctors, and carefully titrating energy delivery. Clinicians must understand the biology behind the letters to transform this checklist into an active, predictive shield against metabolic collapse. The first rule of this protocol is that critical intervention begins long before a single calorie reaches the patient. The R stands for recognizing risk factors. We have to proactively identify which patients are at high risk for a metabolic crisis. This directly connects to the final letter, G, which requires the application of the GLIM criteria. GLIM provides a systematic, globally standardized method to quantify the exact severity of a patient's malnutrition. We rely on these data points rather than clinical intuition. The double E's in the acronym focus on excluding other causes and performing a thorough examination. Before diagnosing refeeding distress, clinicians must rule out alternative pathologies that might mimic these symptoms, ensuring the metabolic target is correctly identified. This initial physical examination and prescription review acts as the clinical anchor. Without a flawless baseline assessment, it is impossible to accurately track deviations once feeding begins. These 4 directives, R, G, E, and E, construct the diagnostic foundation required to safely authorize nutritional rehabilitation. After setting the baseline, we move to the biochemical core of the syndrome, the metabolic correctors that keep the patient stable. The I mandates the correction of key intracellular ions, phosphorus, magnesium, and potassium. In a state of prolonged starvation, a cell becomes relatively dormant, and its internal reserves of these critical electrolytes are severely depleted. The crisis begins when we reintroduce carbohydrates. As glucose enters the bloodstream, the pancreas responds with a sudden spike in insulin. This insulin surge flips a metabolic switch. The cell suddenly wakes up and demands vast amounts of phosphorus to synthesize ATP, emptying the bloodstream of the mineral. Concurrent with this demand, magnesium and potassium are pulled into the intracellular space alongside the phosphorus. This rapid shift leaves the serum depleted of the electrolytes required for basic muscle contraction, leading to cardiac arrhythmias. This is why ion correction must happen before and during the feeding process. Directly tied to this metabolic ignition is the N directive. Never forget thiamine and multivitamins. Thiamine, or vitamin B1, is a coenzyme. Without it, the body cannot metabolize those new carbohydrates into usable energy. If we flood a starved system with glucose while thiamine levels are depleted, the resulting metabolic bottleneck causes rapid neurological damage known as Wernicke's encephalopathy. Preemptively managing these specific ions and vitamins prevents the catastrophic cellular failures that define refeeding syndrome. With the biochemical defenses active, we must address the administration of the calories themselves.
Feeding a patient slowly is only one part of the strategy. The F and D directives work together: feed slowly and start at a low dose, but also decrease energy whenever metabolic distress is detected. Caloric intake must be ramped up from an extremely low baseline at a cautious, deliberate angle to allow the system to adapt. If signs of distress appear, clinicians must immediately regress or halt energy delivery. To spot that distress, we rely on the final E, edema and fluid monitoring. Fluid shifts are a critical lagging indicator. Swelling suggests the patient's body is failing to handle the stress of the refeeding process. This occurs because high insulin levels reduce sodium excretion in the kidneys, forcing the body to retain water. Without rigorous monitoring, this fluid overload builds rapidly, leading to pulmonary edema or total cardiac failure. The F, D, and E directives function as a real-time throttle and brake system. giving clinicians the mechanical control required to navigate the recovery. Looking back at the complete mnemonic, the underlying physiological mechanics are now clear. The checklist builds on itself, binding the individual components together into a single clinical strategy. The protocol functions as an interlocking biological safety net, where every directive supports the next. The entire system demands operational balance. Energy titration must be matched with aggressive metabolic stabilization and constant monitoring. Relying on incomplete strategies, like restricting calories without correcting electrolytes, directly threatens patient survival. Memorizing the acronym serves little purpose without an understanding of the physiological why behind each instruction. By internalizing this systems-based approach, clinicians stop reacting to refeeding complications and begin anticipating the biology, securing safe passage out of severe malnutrition.